welcome everybody. Obviously, ICU teaching once again on a Friday. We've got Jeanette Gross, who's going to be giving us a very interesting talk. It's going to be very interactive by the sounds of it. So Jeanette, you said it's going to be kind of from the interactive from people speaking or from chat?
However you want to do it, guys. There's this is a really rubbish way to teach, isn't it? So I'm in a room on my own talking at a computer and hoping that some of what I've got to say reaches through the internet to you. I got asked by Zoe and Matt to join in one of these teaching sessions with some stuff on human factors and thinking about patient safety incidents. So I've sort of picked a theme of diabetes, hence the sweet surgery. And I hope as we go along that there are some talking points, and to help you work out where those are, I've put a little logo on the slides. And it would be really great when I'm asking some questions, if I get some answers back, either on the chat or if you want to stick your hand up and join in the conversation. Either way works for me. But we will not be moving on from a talking slide if I don't get any talk back. So fair warning. Let's go. What we're going to chat about is a little bit about diabetes, why it's important. I know this is specifically ICU teaching, but I'm hoping that the themes will reach across our specialty boundaries. A bit about patient safety incidents and incident causation, some human factors, guidelines, and then a final little chat, hopefully, about the trouble with guidelines. So, diabetes. There's about 5 million diabetics in a population of, what is it in the UK, 65 million. About 8% of the diabetics are type 1, vast majority type 2. And that makes for about 1 in 10 over the age of 40, which might make some of us on this call want to reflect, but also think about the numbers that you encounter during the course of our work. They make up up to 15% of the surgical population, and with 300,000 operations a year, it's something that we all need to know a lot about because we deal with a lot of it. Poorly controlled diabetes is a cause of an increase in all-cause mortality and morbidity, and increasing length of stay means resources are less available for others. This paper looked at the prevalence and clinical outcomes of hyperglycemia in the perioperative period for non-cardiac surgery. And you can see on the left-hand side there that there is a significant increase in outcomes that we would wish to avoid in our elective surgical population. So they occupy 1 in 6 beds. During a hospital stay, in a year, there's been 58,000 hypoglycemic events. 1 in 25 type 1 diabetics get a ketoacidosis, and 260,000 medication errors, 3 of which we're going to talk about today in a bit more detail. The never event selection includes an overdose of insulin due to abbreviations or an incorrect device. Examples of that are people actually using a syringe to aspirate from patients' insulin pens and then injecting an unknown amount of an unknown strength into a patient who then has a hypoglycemic attack because they've just got double the dose of insulin that they should have had. So the 3 incidents that I want to talk a little bit about today have all happened in this trust. I'm appreciating that this is being recorded, so I'm deliberately trying to keep things fairly vague, but by way of reassurance to the great British public, no patient came to harm and some pretty important lessons got learnt. So as with all experiential learning in the sphere of medical education, I hope that we can share further lessons today. The first case was a patient having a laparoscopic nephrectomy who was a type 1 diabetic. The insulin syringe, or the criteria for a variable rate insulin infusion, were met in that this patient was having major surgery, going to miss more than 2 meals, and was not going to be eating immediately after surgery. For reasons we'll go into, the sliding scale was set up in theatre by the CT and the ODP, and there were 2 pumps running, one at 100 mils an hour, one at 2 mils an hour. Not necessarily the correct rates, just not necessarily applied to the correct infusion pumps. So the patient was receiving 2 mils an hour of dextrose and 100 mils an hour of insulin. Second patient undergoing a coronary bypass grafting, consultant anaesthetist, senior registrar, a perfusionist, a junior trainee working with the perfusionist, and the patient arrived on intensive care post-operatively, where it was noted that a 50 ml syringe of insulin, rather badly marked, was in fact empty, suggesting that all 50 mils had been administered intravenously during the course of a routine bypass graft operation. Patient's BM was low, appropriately managed, and as I said, the patient didn't come to any harm. Third example is an insulin diabetic coming for vascular surgery, was commenced on a VRII on the ward. BMs were noted to be quite low, both on the ward pre-op, not really handed over to the team, noted to be low intra-op and in recovery, for reasons that will become apparent a little bit further on. So how do errors of this kind of magnitude occur? Active failures and latent conditions are the two kind of groups of conditions that kind of make it possible for people to make an error. And the active failures are the immediate causes, the unsafe acts, the frontline stuff. And the latent conditions refer to more generic kind of systemic errors. The organisation hasn't found a way of providing appropriate pumps. There are insufficient IV trained nursing staff on admissions arrivals wards to be able to provide sliding scale insulin at the appropriate time, that kind of thing. I would imagine you're all going to be familiar with how errors occur, and James Reason's work, an alumni of Leicester University, on the Swiss cheese model. Now, there's lots of reasons why. Of course, it's much more complicated than this, but it serves a purpose for just describing this idea of things that are to do with the environment and the system in which we're working, the latent conditions, and the active failures, which are more about the people working in that environment. We all know, because we experience it on a daily basis, that safe systems are not well developed in healthcare, say compared to other safety critical industries like nuclear meds, the nuclear power system. But healthcare really relies on the resilience of its staff to prevent that silver bullet getting all the way through the lines of Swiss cheese. Last Formula One season, there was a fairly spectacular crash, and Martin Bromley, husband of Elaine Bromley, who I think more than any one single person, Martin has done more to change our attitudes and awareness of human factors in the sphere of healthcare, posted this tweet shortly afterwards, which I thought was quite apt and I hope a little bit thought-provoking. But it's certainly how it goes. Okay. Human factors. Everybody loves talking about human factors, mainly because it's got to be all about the humans. So when we talk about error, it's all to do with the humans, right? So I've got 6 points here, and there's a little chat icon just here. So who can give me, either by typing or shouting, some ideas about what constitutes the key non-technical skills?
Communication.
Communication, yes. Don't make me pick on you individually because I can see some names. Anyone in the room with you, Paris?
Yes, I will turn the camera.
Turn the camera around. Hi.
Hello.
Can you think of a non-technical skill? Something to do with how humans interact in the workplace.
Like
Teamwork. I've just got communication, teamwork.
Equipment supply.
Okay, so we'll come on to that. There's specifically non-technical skills. So if you think about the themes of what does a team need to be able to work really well? They need to be able to communicate. What else do they need to do? Who organizes the team? Leadership, yeah. And once you've got your team and you've got your leader, what are you actually going to do?
Look for guidance. Look for guidance from the leader.
Look for guidance from the leader. Yep. So that's going to be about perhaps guidance towards performing a task. Assign roles. That's definitely all good stuff about leadership. So as well as leadership, situation awareness. Thank you, Heather. Situation awareness, teamwork, communication, leadership, decision making and task management are the kind of cardinal human factors that, without us realizing it, are the things that we bring to our workplace every day. So I'm just going to give you a quick little refresh on each of those things. Situation awareness. I really like this slightly wordy description, but I think it kind of covers everything. It's about the perception of the elements in the environment over a certain period of time, the comprehension of what those elements mean, and being able to project into the future what might happen next. What that boils down to is really saying, what is going on? So what? Does it matter? Now what is likely to happen coming up next? And if you've not got eyes in the back of your head, you're perhaps not going to be able to appreciate what is going on, what's about to happen, what will happen in the future. Cameraman's got it nicely though. Teamwork. So that's about a shared vision, a common goal, or a future state, understanding what needs to be done to reach it, so that we're all talking from the same page about where we're going as a team. The reason that's so important is there's actually a lot of evidence in the literature, and I think Paris's journal article is going to kind of come on to some of this stuff as well, that teams that exhibit infrequent team behaviour, like cohesiveness, backup behaviour, working together, their outcomes are worse. And actually, I was in theatre yesterday morning, and the way the day started, it felt slightly surprising that we got through it without something terrible going wrong by accident, but just because it took a bit of time to get everyone on the same page and start working together as an effective team. Some of the reason for that was about communication. Communication is the ability to impart critical information with the potential for that's my typo, without the potential for misinterpretation or misunderstanding, irrespective of the situation or the professional diversity of the surrounding team. That means that in this multinational NHS that we work in, this picture went viral on Twitter and Facebook around the time of Brexit, where all of us foreigners felt a little unloved by the great British public, saying, go away. But that diversity, and particularly in a city like Leicester, means that communication error can sometimes be occurring because of language barriers in a noisy environment in theatre, in an emergent environment where things are happening quickly, and particularly in a COVID environment where we're all in PPE. The other thing to think about communication at work, if you're an airline pilot, to get your pilot's license, you have to learn a textbook of language that is used in communication during flight. Socially, we kind of grow up learning from peers and you know, hearing from each other, or the various cultural events, what's current language, how to make yourself understood. Our problem in medicine sometimes is that we're a little bit mixed. We're using technical language, but at the same time often trying to make it accessible for patients that we're treating. And we can end up using language that might be open to misinterpretation. Leadership, about the team, it's about the task. So when you're a leader, you want to make sure that you're helping the team absorb pressure, you're directing, assigning roles, providing leadership, communicating and coordinating with the other members of your team, all so that as a group of people with a shared vision, you can get that task done up to scratch, managing the constantly changing number of tasks that might come at you on a busy shift in ICU, that you're making decisions, but you're also managing the resources that you've got. How many ventilators have we got? How many ampules of propofol have we got left? How much PPE have we got? Or at the moment, the latest directive that's just come out from NHS England, we need to be reducing, all trusts need to be reducing the number of blood bottles that they're using by 25% to conserve stock. That'll be something to chat about on your next ward round. Leadership in theatres, and I apologise, I had a board meeting this morning, so I didn't have time to change this to kind of incorporate leadership within ICU. But it's always about a sharing of leadership roles that depend a bit on what's happening at the time and what skill set you need in the room. So the leadership in an ECMO bed patient is going to be a bit different to someone who is level 2 and needing a lot of physiotherapy on their chest to be able to get them mobilising and moving on and making progress. So decision making, you know, we do this every day, maybe without thinking about it as a formal thing. But when we're weighing up the options and choosing a particular path to follow, implementing and reviewing our decisions, this is all stuff that we're doing all the time without necessarily thinking about some of the theory behind it. We actually make decisions in different ways. Might be recognition primed, rule based. We might be analysing things, or we might have time to get really creative about the decision making. Generally frowned on in emergent medical situations, but nonetheless has a place. How we make decisions is often based on time and how critical getting it right is. And that might be that we're doing a rapid sequence induction, managing an airway, can't ventilate, can't intubate situation. It might be that we're following the Resus Council guidelines about resuscitation. I realised I am very old because I've got the original Spock in my analytical slide, which for the FY1s the other day when I showed them this, it wasn't. Yeah, I had to explain who Spock really was. The same happens when I use William Shatner as Captain Kirk as an example of leadership. Creative thinking is the other part that sometimes coming up with good, crazy ideas is actually what's needed. And that element is why diversity in teams is really good. Task management is really about task prioritization. Some of you, if you've seen me talk about human factors before, will have seen me present this particular slide. A really useful lesson from the aviation industry about the importance of eliminating distractions and cognitive threats from your ability to perform tasks. So workload is highest when you're a pilot during takeoff and landing, the obvious corollary of that being induction and emergence, or your rapid sequence induction as you're intubating a patient on intensive care. But it actually takes up quite a small proportion of total flight time. However, even though takeoff and landing is a small proportion of flight time, the number of incidents that actually occur during that time is significant. Cruising at altitude, exactly like an intraoperative period of time when we get to do our crosswords, it's the same for pilots, because everything is stable, nothing is happening that's going to mean that I've got to think and act quickly. I've got spare brain capacity to have a chat about something else. However, planes crash when people chat during takeoff and landing, and so the aviation industry in America, or the Aviation Regulation Authority in America, put in an absolute ban on any conversation to do with anything other than takeoff and landing below 10,000 feet. That terms the sterile cockpit. You can imagine through the list there's a variety of things where you could imagine that applies in the way in which we work in theatres and intensive care. All of this is to do with the fact that we as humans are not so different from our own cardiac myocytes. If we get overstretched, we fail. HALT stands for hungry, angry, late or tired, or hangry, often the first two. And there's a list there of a few other items that you can all recognise, I'm sure, as contributing to those times at work where you find yourself actually not able to make a decision because your brain is just overloaded with the extra stuff that's filling up your brain. So that in summary is they're the key human factors that relate to people and their non-technical skills. But you can guess from that long list of other things that there's actually a lot of other items that contribute to the list of human factors. We're working in an organisation that's very quick to want to emphasise that the human hasn't filled out the lock set properly, which is why the guide wire was retained. The human didn't follow stop before you block, and that's why the wrong side was blocked. Those are our two most recent never events. But actually the number of never events in the UK has really not changed from about 490 a year since they came up with this idea of never events. And my personal feeling is that actually these things, we can tell humans to be more careful as much as we like, but unless we're properly addressing all of these items, we're not going to make a difference. So, chat, what are these items? Someone mentioned one before about equipment and design. I'll give you that one. Anyone got any other ideas of the kinds of things that contribute towards how humans interact with the environment and in pursuit of completing a task? Paris, I see you moving. You're about to unmute.
I was just going to say resources and money.
Yeah, someone's typed that as well. Did they do that while you were thinking of it, or did you tell them to type it?
That was me moving.
Oh, I was hoping had someone else contributing. Right. Absolutely. Money. There is no money. We get told that all the time. And yet there's lots of money for consultants to come in and tell us why we have no money when we know that already. It's Friday afternoon. I'm not very on message as a member of the management team, I'm afraid, by this stage of the week. Anyone got any other ideas? What do we use the money for in our working environment? We buy equipment. What do we need the equipment? Why do we pick a particular, yeah, for staff, why do we pick a particular device over another device? Say, for example, if we're buying a new ventilator.
Ease of use. Cost and ease of use.
Ease of use. So the design, the human interface with technology. Yeah. You're on the absolutely on the right track there. Dr. Lissell, good afternoon.
It's always cost, though.
It is always remember.
It doesn't matter how easy it is to use. It's always cost, and of course the service package and the training that everybody gets on that ventilator.
Okay, so service costs, the system, training. I think we're all kind of starting to get onto the same page here now. So when we think about technology and design, ergonomics, equipment, the systems that are in place for using the equipment, the process, and also the organizational reliability. You know, are we confident when we go to the cupboard that the supply chain has actually got the propofol in the cupboard on the day that I need it? Really important part of human factors is the culture. As one individual, I'm not a culture on my own. It's the whole team. It's the whole CMG. It's the whole hospital. So these are the sorts of things that I talk about when I'm in root cause analysis meetings. And of course, in fact, just the other day at Trust Exec, in fact, I raised the issue that once again, we're talking about the people. For example, Dr. Bawagaba, who was one doctor who got sent to court at the same time that there were 73 system issues that needed addressing, because that makes up all of human factors. Everyone went a bit quiet. Anyway, let's talk about culture. Different organisations that are safety critical actually have absolute issues around making sure that they've got the correct equipment and a culture that says, don't come to work if you haven't got these things, if you're not wearing your safety shoes. Another element of culture, what do you, some of you may have seen this one before. This is at a power plant. What do you notice about the cars in the car park?
When you're in a power station or any form of energy thing, you all have to reverse into the space in the mornings.
Absolutely. And that's because if you have to evacuate the site, you want to be driving out. So if I said that this is actually at the administrative car park for the power company, 5 miles away, even though they're not on site, they are still parking in the same way to make them safe. Deeply ingrained culture. Plus, it's much more efficient for leaving rock concert venues if you ever get to go to those ever again. Okay, so that's good human behaviour. What else do we notice about the system that designed this lovely pathway? Stratford-on-Avon, by the canal, they've spent a lot of money on all this paving stones. Did they put them where the humans walk? No. Because human behaviour is to take shortcuts. So even though they're getting muddy shoes, the humans would rather take a shortcut that saves them approximately 3 or 4 seconds. So wouldn't you want to have worked out what the humans do and put your path there? Now you've just got mud. It's interesting, isn't it? Now, before anyone gets stressed, I'm not talking about checklists today, but I do think this point from Atul Gawande's checklist manifesto is important to remember, that we can all make errors, however much training and experience we've had, and however motivated we are to do right. Unsafe acts, unintended action causes a violation, and that means you need to go to the GMC plus minus prison. But in fact, the vast majority of errors in our healthcare system are unintended actions, a slip, a lapse, or a mistake that are in part the result of not being supported by the latent conditions in our working environment. Let's just come back. So root cause analysis always loves one thing to be the reason why something happened, and the criticism of James Reason's description of the Swiss cheese model is that it's linear. Because if we actually get back to this first example of a drug error, it was August. The consultant and trainee had never worked together before, so competencies were not known. The trainee had never set up a VRI before. The consultant worked in an organisation that meant that it's important to get to meetings. We've got to have clinical engagement, but we're not setting the meetings when the clinicians are available. So we're asking clinicians to try and do two things at once, and we all know what happens when we do that. So the consultant says, "Are you happy?" So unfortunately, well, the trainee and the ODP said, "Yep, not a problem, we'll do that." They set it up, they started it going. The trainee went for a break as the consultant had got back. Consultant looked at the pumps, all looked fine. Another consultant arrived to take over the afternoon session, had a bit more of a thorough look around and discovered that in fact the insulin was running at 100 mils an hour. So this raises the issues of training and supervision. And actually the whole kind of flow chart starts to look a bit more like this. There's a couple of ideas here that I'd just like to explore a little bit more, in particular cross-check and confirmation bias. And that all comes from this terrible term, "Are you happy?" Are you happy? Cheers, I'm out the door. Try leaving a trainee in an anaesthetic list or looking after a patient in the HDU as you leave the building without using the words, "Are you happy?" So deeply ingrained. So here's some things that were going on. So this is a duck, isn't it? No? Paris, what is it?
Definitely a rabbit.
It's definitely a rabbit. You and I are looking at exactly the same picture. And if we were both checking this and you said it's a rabbit, I'd go, "Oh yeah, I can see it's a rabbit." But actually, if I just looked at it on my own, I'd say it was a duck. So we end up kind of correcting each other by suggestion if we're not careful, because people will see something different first. So when you're double checking drugs, saying this is something right is the wrong way to do it. People have got to do those checks independently. Chest x-ray, nasogastric tube checked. There it is going down under the diaphragm. Here it is going off into the bed. Happy to use that. Yep, looks great. Everyone happy? No. But when you're rushing, actually that is going there, you can see it there, it's outside the chest cavity and that's going down below the diaphragm. In fact, it's the other way around. This bit was external. COVID environment, never event. So here are the pumps. So this one's going at 100 mils an hour, this one's going at 2 mils an hour. Oops, that's actually the syringe driver and that's the fluid infusion. What do other people say? I don't know if there's other consultants, Ricky and Mike, Jonathan, be interested to hear your comments. When you're leaving the building and going home at the end of your, well, being able to leave, but still on call, How do you leave without saying, are you happy? Because actually it's the kind of phrase that encourages that positive confirmation bias. We all want to tell people we're happy because nobody's got the time to hear how sad we are.
Well, of course,
but actually you want to confirm. As a trainee, you might want to confirm that you're competent. And
yeah, well, of course, we always ask the trainees if they're happy, and we do tend to have a look around the patients ourselves and make sure we're happy with how the patients are. But as you say, communication is key, and it's very easy to put words into people's mouths, and you do have to look at the non-verbal communication that people give out when you say, are you happy? Is it okay if I go?
Yeah, absolutely. It's trying to work out how to actually do that. We say, are you happy, as a shortened version of all of that stuff. What clearly needed to happen in this situation was a proper conversation about competencies. Have you done this before? You know, what are you getting out of this list? Have you got a safe space that means that you can own up that you don't know how to do something? Mike?
To be honest, you just need to flip that question of are you happy on its head and just say, are there any issues? Is there anything that you're concerned about? Because that immediately removes the fact that you're challenging a consultant to it actually being an opportunity to ask a question.
That's brilliant. Why have I never thought of that? Lifelong learning, folks. You're seeing it here, live in action. This is the importance of being in a room and having two-way conversations. Ricky?
So I think I might take that even a little bit further and sort of try and sort of encourage it by saying something along the lines of, you know, what problems do you have that you want me to sort out, really, or sort of try to encourage that. I think your point of are you happy? I think the reaction is you want to say yes and that's it, or as a trainee, if you feel like you say no, you're kind of, oh no, I'm not coping. You know, if I say no, that I'm not happy. I think it's probably trying to encourage people to speak up, I guess, and say, you know, what is there anything, what can I help with, or what you know, encouraging them and sort of giving people that freedom to talk up about what's kind of their worries, I guess, and almost assuming that there are problems and that's normal, that's acceptable, really.
Yeah, absolutely. Any trainees want to make any comments? Do you think your consultants are properly understanding what it's like, or have you got a different perspective? Can't hear you, Paris.
The conversation varies depending on what
You're too far away from the microphone there.
the conversation varies depending on what time of the day or night it is.
Yeah, so like lots of communication, it's going to be relative to the context, isn't it? Shall we have a look at another one? So this was the patient undergoing a cabbage who ended up on ICU with an empty 50ml syringe attached to them. It was normal practice, my usual practice, just to have it there in case. Patient wasn't diabetic. Perhaps some issues of supervision, patient monitoring, and situation awareness. The perfusionist trainee had beautifully documented the blood gases during bypass and the low glucose. So it was actually about interpretation of information. There might be also something about being task focused. So the trainee, you know, it's really important, isn't it, to give the senior trainees the opportunity to be managing the whole case. And it is also important to recognise that sometimes that might mean there is a much higher level of working going on than someone who's an experienced consultant performing the same task. Standardization of syringe labeling as well is another one that kind of comes up with all of these sorts of incidents. So just that idea of cognitive overload again. If it's a difficult task or you're not very experienced, your level of stress is going to hit high very much sooner than if you're an expert with plenty of experience in an area that you're very comfortable and familiar with a really great team, with no COVID, and perhaps the sort of personality traits that mean you're able to absorb, or even a good night's sleep that means you're able to absorb some of the stress more easily. Any questions about that or comments? Okay, this is why drug labeling's a thing. Sorry, it's a bit blurry. I must have had a bit of I've got a bit of a shake. So benign essential tremor before anyone asks. Look at this variety of classes of drugs that sit in our cupboards. And this is part of the human factor stuff. Who's designing these boxes and these colours? What supply chain purchasing practices mean that we're prepared to put these accidents waiting to happen into our cupboards? And the reality is that for some drugs, there is global shortages, single suppliers, and there is no standardization recognized globally for the color labeling of drugs. So orange must be the cheapest color. Well, men that are red, green colorblind often really like orange as well, because that's apparently a little bit easier to see. Don't know. Moving on, final one. So diabetic for vascular surgery, brilliant. Patient's going to have an all-day operation at the 3-stage vascular procedure of doom. And they were hooked up to their insulin infusion. BM's a bit low. That would be because actually the ward had also given them their full dose of subcut insulin in the morning. And that bit never really got handed over to anybody until everyone was trying to work out why the BMs were so low. So that kind of highlights particularly this one here, safe handover. Again, the patient didn't come to any harm. They were safe, appropriate management, but it does raise some real concerns about training and education and understanding how that patient should have been properly managed. So just quickly, I'm conscious of time. Safety 1 and safety 2. This is how it works in the nuclear power industry. This is how we work. Start and finish. We get the job done, but every single day this squiggle will be slightly different. And this is why in healthcare we are moving towards more of a concept of Eric Holnagel's safety 2, that actually it's important to understand that things go wrong and things go right with the same set of people and the same circumstances on a different day. And that's where some of those human non-technical skills and that resilience of our staff may be influencing the outcome on any given day. We've got to focus on safe operation and making sure that we're understanding when it goes right, what were the things that supported that. Now, again, checklist manifesto. I'm not going to go on to checklists, but guidelines, I guess, fall into that similar field. It's about collating the most up-to-date information, spreading best practice. Bit like if you look at the NELA guidance about perioperative management of laparotomy, the variation in standard of care and standard of outcomes it depends on your postcode, sometimes even within the city in terms of access to intensive care beds. Not at the moment, but in times past, your likelihood of being cancelled was far, far greater at the Royal Infirmary than the Glenfield, for example. Okay, so best practice guidelines, lots of them about diabetes, because obviously, as I've mentioned earlier in the talk, it's a serious problem affecting lots of people, and we've just seen 3 examples where potentially we could have had a catastrophic outcome. Within a UHL, on your policy website, you will find diabetes guideline for surgical patients. Actually, there's a wealth of information in there, and I would commend any trainee to be aware of how to find it and to read it and have a look at it. And in there would have been all the stuff that could have stopped any of those incidents happening. Why don't we follow guidelines? Anyone got some thoughts? Paris?
We're just saying that there's so many guidelines, and there's a bit of guideline fatigue almost.
Absolutely. It's same with checklists, everything. It's like the amount of knowledge that you've got to have in your head as a doctor now. Difficult to access, yes. Thank you for that comment. I'm sorry, we can't hear you.
Limited devices.
Yep. So infrastructure, time pressure, you haven't got time to look them up, but what if they're telling you what's the right thing to do? I know, but I don't need to change my practice. My patients' outcomes are excellent. Why should I change? I've always done it like this. For the last 20 years, I've done it like this. Everybody's been fine. Have they? I don't know. We don't collect that data necessarily. The big thing for some people, actually, I'm pretty sure that I've been a reasonably safe doctor all this time. But if you're telling me I've got to follow this guideline and change my practice, have I been doing it wrong? Have I been harming patients? That's just not acceptable. That cognitive dissonance is not acceptable. Therefore, I don't want to look at those guidelines because I know that what I'm doing is safe. I don't want to change because actually change is hard. Might make you feel a little bit sick. There's a whole committee on why people don't follow guidelines in Europe. And I think we've sort of touched on the key ones here already. How do you get hold of them? You haven't got a computer. And even if you have, I have to say now, the UHL policies guideline button, if you know the right words to put in, and I will say diabetes and surgery is all you need, they have got more accessible, and they are working quite hard to make sure they're actually current and that you don't put in diabetes and surgery and get what we were meant to be doing in 1969. But how do we handle the educational value of introducing those? Same with the LOCSIPs. Why aren't the LOCSIPs working? Well, have we taught people how we want to use them properly? Have we shown them? Have we actually thought about the right accessibility of the forms that we want people to use? Actually, if you're putting in a line in theatre, you don't get the LOCSIP until you've already opened the sterile packet, positioned your patient and got scrubbed. So you've done half of it already. Lots of reasons. This is my favourite though. The one page that you need for your nasogastric tube policy is actually somewhere on page 27 of a 31-page document. So that's pretty much all I wanted to talk about. And I would be really interested to hear if anyone's got any questions or comments on some of those things that I've touched on. And while you're thinking about your questions or comments, I just want to leave you with this thought from Sally Sullenberger. I think this is quite an important point for us to remember about the importance of speaking openly about patient safety incidents, about properly understanding why they went wrong, not just the human was bad, the human didn't use their non-technical skills, or they've got bad human non-technical skills, but actually understanding the system-wide issues and making sure that we're integrating the system into our response to learning from incidents. Thank you very much.
Any questions from anyone? So I've got a couple of things. So you talked a bit earlier about the sterile cockpit on in theatres, on kind of intubation, which makes perfect sense, really. Obviously, with this being kind of more ICU related, clearly on ICU when you're intubating someone, again, that's a very sort of high risk procedure, and you need kind of all hands on deck there. But what about sort of other things that we do on ITU, like the ward round or handover? Do you think that should be sterile?
Absolutely. Well, another example would be drawing up your infusions. We had a case of a cardiac arrest on ICU at the General, probably because the antibiotic was mixed with potassium chloride. And the member of staff preparing that was being distracted by a relative taking photos in the intensive care, It wasn't just one thing, it never is. So I've actually caught myself a couple of times. I'm quite distracted when I'm at work at the moment. Yesterday in theatre I had 3 people queuing up to talk to me about things. So I'm actually starting to get quite strict about my boundaries when I'm drawing drugs up. I don't talk to anyone now. I found myself drawing up a drug and putting the wrong label on the syringe. I think that kind of lapse through distraction is far easier than we realise. And I think drug preparation, complex decision making, and certainly handover, not being interrupted while you're in the middle of that is really, really important.
Yeah, Paris.
Yeah, I was just going to add to that and say that on some of the anaesthetic doors, they used to have signs saying anaesthetic in progress, so that for that very reason, for people not to disturb. And I think on the wards they had the nurses wearing like almost like a bib or a sign saying that they're doing drug round.
Yes, drug round.
Yeah, so that you're not disturbing them while they're doing the drug round. It's highlighted that. But yes, they had to wear literally a high-vis bib. Drug round. Here on intensive care, we have handovers in separate rooms. The doctors do the handover in a separate room away from the unit, again to try and prevent that, that disturbance that could happen. And the nurses have their handover in a separate area as well, so that again they can do their handovers separately, quietly. And
I think the other reason it's really important in intensive care is that as with performing any system check, if you get interrupted, you assume you're going to go back to where you were when you left off, but you might not. And so you might accidentally miss out reviewing the renal function and urine output. I know you wouldn't, Ricky, but somebody with a less vested interest in the kidneys might. My point being that that's one of the dangers of an interruption, is that the human, we have if your default is faith in your own invincibility, then that's when you're dangerous, because you'll imagine that you will always go back to the same place, but you might not. Which is why I like checklists, because I know I am not invincible. Don't tell Mr. Miller that.
I've got one final question, really. If there was one thing you would, let's say you had all the money in the world and there's one thing you could change for the NHS to make it safer, what would that be?
IT.
Okay, go on.
And training.
You're only allowed one. You're only allowed one.
No, training in the IT. Okay, so the IT package. Yeah, there isn't just one, is there? But I personally think infrastructure is so important. I recently went to Chase Farm, which is a standalone treatment centre, part of the Royal Free Trust, North London. And it's a very pretty building. It's not complicated, fancy, pretty. It's just clean, bright, big windows, white paint, smart and tidy, because everything is electronic. And actually, the building is completely secondary to the IT that enables patient pathways and staff working in ways that makes it efficient and safe. So yeah, and on that subject of IT and training, yesterday I showed a junior doctor about CITO, CITO, which is on the drop-down menu of the favourites on all trust computers. While I've got a few people here, I will continue to spread the word, because it seems that the trust has an IT system for all clinic letters that it's not told anybody about. So if you are seeing someone pre-op and you haven't got the notes, have a look on CITO and you should be able to find, or they scan all the ED attendance stuff, which is largely unhelpful. However, they will have all the clinic letters there. So with that and the investigations on ICE, you can usually construct a far more detailed picture than trying to rummage through volume 3 of the notes of the complex renal patient.
Yeah, I only heard about CITO, I think, about a week ago myself.
Yeah,
and,
yeah. They've been using it over a year.
It's crazy. How have we not heard about this?
Yeah, yeah. Well, you have now. I feel like my work is done.
There's always respect for the ward round and how
I'm really sorry, just like last time, because you're so far from the microphone, we can't hear you.
There seems to be, in comparison to some medical wards, more of a respect for the intellectual processes that go on the ward round. You go to a medical ward and then do a ward round, you'd be interrupted 100 million times about discharges and TTOs.
Yeah.
So your plans become poor because you're being interrupted continually. Whereas, you know, in others, in the ICU setting, there's a lot more respect for that as a process.
Yeah,
and
brilliant.
Important.
That's great to hear.
Any other questions from anyone? Otherwise, I guess we'll draw that to a close, really.
Oh, thank you very much, everyone.
Thank you. Thank you very much. So we've got Journal Club now. So Paris is going to present a paper for us. I think she's getting things set up.
Yeah, so in keeping with Jeanette's talk about human factors and the problems that can occur in, well, team performance, I found this paper, an interesting little paper online. Well, Ricky and I found it, and it's basically talks about how exposure to incivility, and by incivility I mean rudeness, can hinder clinical performance. And they did a little experiment to see whether that's actually true. So what I'm going to talk about is why they conducted this experiment in the first place. I'll talk a little bit about the paper, some of its strengths and weaknesses, and then hopefully we can have a bit of a discussion at the end of it. So I shouldn't take too much of your time. It's going to be a brief overview of the paper. I have sent the paper out so you can have a look at it in more detail later on, should you wish to. So why did they do this paper in the first place? Well, there are loads of examples in industry, which Dr. Grace talked about in terms of aviation industry, nuclear power industry, where they've done loads of experiments, had loads of reports whereby they've done loads of tests and shown that actually clinical performance, well, performance in general, team performance in general, is hindered by people who are rude and abrasive. And it's quite an obvious problem that happens on a daily clinical basis. And in one study, again, this is an American study, they reported that up to 98% of anesthetists, or anesthesiologists as they like to call them, reported having experienced some sort of rudeness in the theatre setting. So they did this experiment to see whether this actually has an impact on clinical performance. So the journal was published in BMJ Quality and Safety Journal in 2019. It was conducted in USA. It was conducted across 3 sites in New York. They say it was randomized. We'll talk about that a bit later. And it was an observational study. What they essentially did was they looked at a scenario, which was basically intraoperative hemorrhage. They used this scenario because it was a standard scenario that they use as part of their board examinations, so like their OSCEs. They created 2 scripts. One script was considered to be rude, and by rude, they had an inpatient surgeon. They didn't use any abrasive language or any sort of physical, they didn't have any physical reactions to anything, but they were just being very impatient. And the other scenario was considered to be a normal scenario whereby everybody was very polite and kind to each other, basically. So, so they created the scenario. They created 2 scripts. They validated the scripts by 3 consultant anaesthetists who were unaware or blinded from the study. So they didn't know why they were looking at the script, but they validated it to see if it was realistic, basically. They then got 3 separate anaesthetists as raters to basically look at videos of anaesthetic registrars going through this clinical scenario. And these anaesthetic registrars were videoed and exposed to either a rude scenario or a normal scenario, and this was randomized. The registrars that were picked were across 3 centres, and the way they picked the registrars was that they shouldn't have any ongoing disciplinary action. They haven't taken any time out of training and not just like returning back from a hiatus in training, or they're not struggling with the examination, board examinations that they have in America. And this is to try and, again, reduce confounding to have to avoid people who may potentially have low confidence or not be familiar with the clinical environment. And again, they picked registrars on the basis that they have some sort of anaesthetic experience on the background before they expose them to the scenarios. They then picked a scale of how they're going to look at the different aspects of the scenario. So the raters had to undergo 1-day training to familiarize themselves with this grading sheet, and they had to look at example videos of the scenarios so that they can try and score them and get familiar with scoring them between each other. So they first looked at specific things like whether the trainee gave IV fluids, whether they used vasopressor, etc. And then they looked at this sort of holistic approach, which I'm using the mouse to look at the bottom here to see where they scored. And then finally, the last bit, they asked the clinical question. You might not be able to see it properly, but it basically says, did the participant perform at the level expected for their grade? And then they collate this information. Now, each of the anaesthetists that were rating were blinded to the fact that they were looking at or assessing videos whereby people had been exposed to a rude surgeon. And they were also told not to grade any videos where they recognized a trainee, but at all costs, they tried to blur out the trainee faces so that, again, it was blinded as much as possible in terms of who's participating in the video. They also sent the videos in batches of 3 to the raters, so that they rated 3 and then got a separate batch, and the batches tended to be from another hospital that they worked at. So the raters didn't get videos from the hospital that they worked from. The scenarios were otherwise completely identical to each other, so the same parameters were used and the same sort of things happened in the timely manner as expected. So going into the results, they essentially showed that being rude hinders clinical progress, and this across all the parameters that they tested, which were all sort of statistically significant. They actually managed to get hold of, I think it was about 76 people participated, but of those 76, they used 67 videos. The reason why there was a bit of a dropout was because some of the videos were incomplete or they were poor quality, so they had to get rid of those. They did a power analysis, and in order to get a power of 0.8, they found that they needed 55 videos, so they met this power analysis. And the results essentially showed that there's no difference between the different groups in terms of their gender, etc. They did a survey of the participants 4 weeks prior to them undergoing the scenario, where they looked at their personalities. So they used a couple of personality surveys looking at whether they suffer from fear or anxiety. And again, using this, they analyzed the data and said that actually that differences in those scores didn't make a difference to the results. The results were almost purely down to the rudeness. Interestingly, the self-scoring, so after the registrars went through the scenario, they also had to do self-scoring. Interestingly, they scored very similar across both control and exposure groups, so they found no difference when they were self-scoring themselves. And the overall clinical performance, according to the raters, was significantly different as well. So this pie chart shows that there was 63.6% thought that the people performing were adequate for their level, whereas it's 91.2% in the group that was the control group. So there's obviously some strengths and weaknesses. So they tried to use a standardized scenario. They had the dialogues and the script validated prior to using them, and to make them as authentic as possible. And they tried to blind each stage of the process. So they blinded the consultants looking at the script, the raters, the anaesthetists undergoing the scenario. So they tried to, try and reduce the amount of confounding factors as much as possible. The obvious weaknesses are that obviously the definition of rudeness varies from person to person, and the state of mind. So one day you might find that one comment is very rude, but the next day you don't care. So that's obviously an issue there. Surgeons are the ones who are always portrayed as villains, so which is probably true in most cases, but we know that that's not always true. Not all trainees were included, so I think, as I've mentioned, that they excluded trainees who were potentially undergoing any disciplinary action, or who were struggling with their exams or things like that. So not all of them were included. It is a small study in that only 67 videos were used. They did have 104 participants initially who consented, but when they did the surveys about personality, they didn't receive all the surveys, so there was a dropout from 104 as well. And it was only specific to one type of scenario. And again, this is a simulated scenario, so it wasn't real life. But obviously, ethically, you can't do this in a real life scenario. And there's no assessment for the current state of mind of the trainee prior to them doing their scenario. So there wasn't any survey on any sort of scale of what their state of mind was like immediately prior to them doing the survey. So if a trainee had undergone something personal that day, or if they were finished a night shift or anything like that, could have been confounding factors as well. So obviously this is quite a small study. It's only looking at one aspect of human factor problems and potentially, but I don't know, anecdotally I could say that I've experienced personally loads of problems whereby there's been rudeness in theatre, and a lot of times it's pretty much ignored. I don't know whether anybody has any feelings about whether people should just grow thick skin, or should they just be nice. And again, even if one of the things I was thinking about is, how do you change behavior? Does it require a critical incident to be able to change behavior? So anyone want to share anything regarding that? So one of the questions were the groups the same for, what was the question, sorry? Yeah, so one of the question was, were the groups same for male and female? And yeah, so the groups were basically the same. So they were pretty even across male and female, and even the surgeons were that they used in the hospital, I think 2 of them were female, one of them was female. Any comments about whether people experience rudeness on site, and whether that has affected their clinical performance?
Jeanette, I think you had your hand up first. Do you want to go?
Sure. I can remember being made so upset that my eyes leaked when I was a trainee by a surgeon being very rude to me, a female surgeon as it happened. I don't think rudeness is specialty, gender or ethnically specific. And I absolutely do not believe that we have to have thick skins. I think we have to behave in ways at work that would make our mothers proud. And I think mutual respect and politeness is the starting point for any civil professional interaction. And I think the cliches of nasty surgeons, please don't think I'm sensitive about it just because I married one. I mean, he's all right. And in fact, he has once sent me to the bottom of the garden for swearing at him. So if we're talking about incivility, it's definitely not always the surgeon who's bad. That might be oversharing. But I do think it's really important that as senior clinicians, we role model the behaviour we expect to see in our working environment, and we have zero tolerance for guests that do not exhibit the same behaviours. Might be easy for me to say I've got a thick skin, except I haven't really. I've just learnt how to set some boundaries for behaviour around me, and if I'm not prepared to stand up for it, I can't really expect my juniors or my theatre team to do it if I don't too. Those are my thoughts.
Mike, got your hand up?
Yeah, it's a lot of thoughts with this one, really. I know, particularly in the last 18 months or so, and some may have experienced me before that I have been both on the giving and the receiving end of this, and some may have experienced me as what's called an angry Wookiee, and I've gone into situations where and essentially torn strips off other people, and I know what the reaction is, and certainly the reaction following that is, and it's not good. It's not good for the patients. It's not good for relationships, and it's certainly not good for me, because what normally happens is that I do that, and then about 10 minutes later I massively regret it, and I'm quite embarrassed about it, to the point where you end up probably ruining a relationship for the next time that if someone wants to refer a patient, especially going into somewhere like ED, and telling them off for not calling you, and then the next time telling them off for calling you, and etc., etc. I think to be able to put it into as simply as whether it's just an angry reaction or a rude reaction is probably massively too simplistic, because there are so many other factors, being human, that you have to take into consideration before you even get into work, let alone what happens at work. And people have a lot going on which you have no idea about, and to be able to turn around and say that you have to remove that, and to act civilly towards absolutely everybody all the time. Well, we don't all live in New Zealand, so it's or Canada. So it's not always possible, but it's I would say that it is very simplistic from that side, but it's a nice little study to show one way or the other. The one thing I just wanted to check, my connection zoned out when you were talking about the design of this. Did they put the same people into the nice environment and then into the nasty environment?
No, so they just randomized the trainees and just put them into a scenario, and I think it was the person who's reading out the script of the surgeon, or saying the script of the surgeon, would last minute choose which, not they wouldn't choose, but they'd be given the script. Okay, this is the rude one. So I don't think they went through I don't think each trainee went through the same scenario twice.
Well, there would be a useful, if you wanted to repeat that, a useful way of looking at that and putting the same trainee, not through the same scenario, because there of course would be performance bias based on the fact they knew what was what the scenario was, But certainly going through 2 different scenarios and seeing if they did better in overall, again, it makes it not quite as accurate on the one where there was a more professional relationship.
Yeah, I couldn't agree more. And like you said, Mike, I think particularly to this study, the definition of rude varies. And for me, rude would be to the point where somebody actually starts swearing and throwing things. Back of the hand comments, I wouldn't really I'd ignore. I mean, just the other day I was in a cardiac arrest down on CCU, and again, the cardiologist said something, and the paramedic actually just walked away without giving the full amount of information because they were so offended. And again, I didn't even realise that the comment was rude. But I mean, in that scenario, in that critical situation, you can get potential problems. But like you said, Mike, you don't know the state of mind of the people who are, one, receiving the comment, but also saying particular comments.
I know you've got your hand up, Jeanette, but I would
no,
say
go.
I would say that if you were the feeling that the off the hand comments and things that shouldn't really count, then that means that you have been fully Stockholmed by Leicester and by coming into work, because while there are, of course, everybody's going to react differently and everybody has their personalities about them, being willing to accept the smallest things which chip away at your personality means that you've already given up.
Yeah, I was just going to add that a situation has recently arisen where we've got 2 people who do not want to work with each other on the basis of an eye roll. Apparently, obviously, there's a lot more to it than that, but it is actually often the little small death by 1,000 cuts that is what results in chronic undermining and people ending up not wanting to work in a certain environment. And that's not good for the individuals, it's not good for the patients, it's not good for the rest of the department, because those kind of things get picked up on. And I think it's a little bit like bullying, that the definition is if you feel like you're being bullied, you're being bullied. If you think someone's being rude to you, granted, there's going to be a range of cultural norms for what that looks like to people, that we just, I don't want to turn into Gattaca and, you can't tell a joke anymore, or you can't tell the inappropriate jokes anymore. But actually what fits as inappropriate is something that we all need to be perhaps much more sensitive to than we were 20 years ago, perhaps. That's just reflecting society and expectations of civil behaviour towards each other, which at the moment in the crazy nuts world that we're all living in out there is never more important than it is now, when we're all a bit tired, we're all a bit done, we're all a bit broken to one degree or other. So the more that we can spread that pause before exploding, the better.
I think that's quite nicely, sorry about the background noise, that's quite nicely concluded by Jeanette there. Unless anybody's got any more comments, I'm just going to show this week's QR code, which is for the feedback. So the feedback will be for both Dr. Gross's talk as well as my talk. The other comment that I'd like to make as well before we conclude today is that if anybody particularly wants to journal club and have dates and journals in mind, please contact me. If I'm not able to fill up the calendar, I will pick people and I will pick a journal out for people. So we are trying to do it 1 a week at the moment. I know the original email for the teaching said that we will try and do 2 papers a week, but at the moment we're just going to do 1 a week. So I have got some names down, but please do email me so that I can collate names and put them down on the calendar. If you don't have any particular dates, I will just look at CLW and sort of look at when you're at work and do it for those days. So yeah, again, there's my email address on the slide there. Please email me if you're interested in presenting for Journal Club. Over to you, Ricky. Thanks.
Yeah, I think that about wraps it up really. So thank you everyone. I hope that's been useful. I think it's been really good, interesting chat amongst it all actually. It's a lot of things to think about, a lot of things to take away really. Hopefully that's been useful to you all, and yeah, please fill in the feedback. I think next week we've got pancreatitis. We're going to be talking about pancreatitis and its management. And apart from that, yeah, we'll see you all next week then. All right, thanks very much everyone.
Thanks Ricky, and thank you Paris for inviting me. Cheers.